My name's Chelsea. We're going to do an epidural placement today. So first I'm going to go in, introduce myself. My name's Chelsea. I am a student nurse anesthetist. I'm going to do your epidural today. Can you tell me your name and date of birth? Awesome. And then we're going to explain the plan. So I'm going to have you sit up on the side of the bed. We're going to find the spot on your back where we're going to numb you up real good, and then we're going to place the needle into your epidural space, put a catheter in, numb you up. There are always risks, so anytime we put a needle in, bleeding, the risk that it may not work, we may not be able to get it, and then we'll have to try something else. Always a risk of nausea. If we go a little too far, it can cause a headache, which would require you to lay flat. And then obviously, anytime we're going near the spinal cord, nerve damage. Very rarely the spinal or the epidural can go too high, cause respiratory depression, could end up on a breathing tube. It would just be temporary, and then obviously any procedure could really result in death. That's very unlikely. Benefits is this going to give you better pain control and hopefully help you relax and progress through your labor. So if you are okay with that, we're going to have you sign a consent. Awesome. And then I'm going to have you sit up on the side of the bed while I get my kit ready. And this is a sterile procedure, so I would have on a mask, hat, gown, and gloves. All right. And I'm going to clean the patient's back. So I'm going to take iodine, get these nice and soaked. I'm going to scrub around the site and in a circle, toss. And do that 3 times. In a circle, toss, get that nice and sterile. Anything dirty would not go back onto the fill. And then we're going to put on our drape. And we're going to let that dry. So, and I could do this either before I got all sterile and ready for the patient or after. You find the hips, and then you go over from the hips, and that's going to be your L4 vertebrae. You can mark it nice and good with a fingernail or the top of a cap, and that's going to give you your landmark of where to go. So we have our position right there. And then my kit is going to be prepped with 3 mils of 1% lidocaine. This is going to be our local anesthetic. We're going to draw that up, get that ready. We're going to drop our test dose, which is 1.5% lidocaine with epi in it. The epi concentration is 1 in 200,000 or 0.005. So that will be 3 mils. And then we're going to get our glass syringe ready with 4 mils of NS and 1 mil of air for our loss of resistance. And we will prime our filter and just have everything else ready. So now we're going to numb up the patient. We'll let her know this will just feel like a little bit of a poke and a burn, and then it should help for the rest of the procedure. Again, make sure we have our landmark, 2 Pierre's line, L4. We're going between L3 and L4. And we're going to just go in at the same angle we think our epidural needle will go in. So we're going to do a little skin wheel, and then as we go in, we're going to just give little bits of that lidocaine. If we're not quite sure on landmark, we might fan out and get a little lidocaine all over. And we will let that numb up. And then we're going to take our epidural needle with the stylet in. We're going to use, this is a 2E needle, and we're going to use a bromage grip. So this is stabilizing on the patient's body. We're going to just insert that catheter, a little cephalad, go in until we get a little bit of stability in the interspinous ligament. And then we're going to take off our stylet and put on our glass syringe, and with our bromage grip, we're going to advance the 2E needle just 1 centimeter at a time while putting pressure on the glass syringe waiting till we get that loss of resistance. So we have a nice bounce. And there's our loss of resistance. So that is about 6.5 from the skin. Now we're going to attempt to thread our catheter. Once we get to that black line, that's coming through the needle, so into that epidural space. And we're going to want to go, so 6.5 plus 5 is going to be our depth, so that will be 11.5. We're going to get kind of to the back mark, and then we're going to hold that, pull out our needle while putting resistance on the catheter until we can grab the catheter. Get that out. So now we're going to check our depth. So it was 6.5 to the loss of resistance, and then we want to be 5 in the epidural space. So again, 11.5, we're at about 15. So we're going to pull back 14, 13, 12, about 11.5 right there. So now we will put on our connector. Secure that down. And then we're going to do our test dose. So we're going to educate that our test dose, so Lido 1.5 with Epi 1 in 200,000, 3 mils, is going to just be a test dose. We want to let the patient know, to let us know if they feel anything funky, if they immediately feel any numbness or tingling in their feet, warm sensations, or if they feel like their heart is racing, lightheadedness. We'll watch our vitals as we're doing this. So we're going to inject our 3 mils lidocaine, and then we're going to give that a minute to see what our effects are. As long as the patient does not feel any of those things and around 3 to 5 minutes starts to feel some warm analgesia kicking in, then that's great. If they do feel those symptoms, then obviously we need to reevaluate our catheter placement. So she doesn't feel anything 3 to 5 minutes later, so we are good. We can take down our drape and secure our catheter. We have this awesome little foam piece. And then you would put a little J-loop, and then we're going to put a tegaderm over the insertion site so that we always have visualization, and then we're going to tape the tubing up the patient's back so that that will stay in place if they move around. And then while we're sitting here for the next 15 minutes, we're going to get vital signs Q5, and then we will chart our procedure and maybe come back in and check on the patient later to make sure it's still working.